Now it's going to adjust off there. That's what it's doing. My light is playing in the background. All right, Jessica, I think we figured it out.
Okay.
Otherwise, I don't know why. All right, so far so good. So musculoskeletal system. Start on it with the trauma and go over kind of the anatomy and phys on it, how we go from there. So the basic parts of the musculoskeletal system, we have the bones, which provide the framework and the strength and also the protection too. When we start thinking of like our ribs and our skull and all that, it's the framework and also a protection for our organs. Joints is what allow the bending and movement. Muscles provide the energy for the movement. Cartilage and ligaments. So tendons, so your cartilage is what provides the flexibility from the muscle to bone. When we start talking about specific parts of it though, remember your ligaments are always going to be a bone to bone. So like your knee, your big ones in there, your MCL, your ACL, that's a bone to bone. And then your tendons always go from a muscle to a bone. Anatomy of the bones. When we look at it, they're formed of a dense, and it's actually connective tissue. So when you guys do, if you ever do an advanced anatomy and phys, it technically is a connective tissue all in itself, but it's just dense and compact. And so there's not a lot of movement that can happen there. It's susceptible to bleeding and injury, especially the two big ones that we really worry about with bleeding and injury are your femur and your humerus, just because, and it's not necessarily the bones that are bleeding, but there's a lot of vascular around them. Your femoral vein and artery, if I could think tonight, and then you have your brachial artery and vein that go by your humerus that can bleed profusely too if broken. And then your joints are where bones meet. There's a picture of it. If you guys ever want to know, there's 107 different bones in the body. You want to really go crazy, take an anatomy and phys and get to learn all of them. I would strongly suggest not unless you want to do. Anyway, no, it's good. It's good. It's just a long, hard class. So the anatomy of the bones, we break it down into different classifications. You have long, short, flat, and irregular. So what would you guys say is a long bone? Femur is a really good example. What about what would a short bone be? So yeah, your wrist and your hands, and then also the bones in your toes too. Okay. And then your flat bones, what would you consider a flat bone? Scapular, shoulder blade's a big one, and then ribs are your other one. So you guys hit all of those, and then your irregular bones are your vertebrae. They're not really a shape, flat, long, or whatever. They're just a unique shape in itself. Some of the cool things about bones, though, because they are connective tissue, they are self-healing nature of the bone. It causes swelling. It's a blood clot in the fractured area, but then it also begins to start to heal itself and rejoin those connective tissues to make the bone stronger again. Where it becomes an issue and why when you guys are going to start talking about splinting and bandaging, that we have to make sure we have a pulse distal or away, further away from the heart from the injury, is if we get interruption of blood supply, we can cause death to that injury site as well. Cells further the fracture by rapidly divide, forming a tissue that heals and then develops into a new bone. So if you guys look at it, you guys can see on an x-ray, the old bone or the new bone kind of grows over and does a hump, or like sometimes you can see the scar tissue or scar bone. And then it eventually, the longer it has to heal and the more times you actually pull and stretch on that bone, it'll slowly pull back in, and that hump or where the bone was connecting heals itself. When we start looking into muscles, we have 3 different kinds. We'll talk about those. For you guys, there's not a lot other than you need to know skeletal is voluntary, meaning you have control of it. So if I want to reach down and pick up something, I can physically tell my brain, we're going to reach down, we're going to pick up my phone, and I'm going to touch the screen and wake it up. Smooth muscle is involuntary. So it's your cardiac, or your digestive. A lot of that is all smooth muscle too. You guys, we don't ever have to think about it. You eat, and then your body pretty well takes care of it. And then you have cardiac or mitochondrial. The cool thing with it is it has automaticity to it, meaning it will create its own electrical impulse and fire. It's the only muscle in the body that does that. And then the cartilage between it forms the flexible structures of the body. So that cartilage attaches to those muscles, and then to the, cartilage is new forming bone, right? So as your bone, it has a cartilage in it that allows it to grow and grow and grow. And also when you're younger, gives you the flexibility to, when you guys have children, that's too why their bones are still there. You've got a lot of cartilage to them, and it's softer that way. So tendons allow for the power movement across joints. So MTB, muscle, tendon, bone, or a ligament supports the joints and attaches the bone ends for stable range of motion. So that's the bone, ligament, bone. So like we talked, the knee, there's your good ones that says a ligament. So you have your MCL and your ACL, and MCL, ACL, LCL. Anyway, there's the 3 ligaments there that you guys will see. The MCL and ACL, usually the ones in EMS that we're going to see damaged if they, somebody in sports took a hard hit to the side, and it'll bend and rip those ligaments. Or somebody jumping off a truck, getting bucked off a horse, a 4-wheeler, anything causes a really hard hit to the side of that. And then your ligament or your tendons is your kneecap. So they go from the kneecap up to your thigh and then down to your calf too. And that's, so the ligaments are for support and strength, and your tendons are what provide the muscle to do the movement. So some mechanisms of injury when we talk musculoskeletal, direct force. So that's what I'm talking to. If somebody takes a direct hit to the side of the knee, that would be more of that's your direct force. Twisting or rotational force would be so I'm trying to think of an injury other than an assault, but if somebody grabs your arm and twists it, or a farming accident, so you get your hand in a PTO or any piece of industrial, and then we'll grab it and just start twisting, and we're twisting a rotational force. And then an indirect force would be, the direct is a hit, so an indirect would be the car. Somebody hits the car, goes to the seat, and then to you, and then back. So it's not, you don't take the brunt of it. It's indirect force to you guys. A rebound force is kind of the way I've always had to look at it. It's more your body's just rebounding back and forth from that. So a fracture is any break in the bone, and we classify it for you guys, like we're going to talk about these communicated, green stick, angulated. For us, what it really comes down to is that first one, is it open and closed? Meaning, is the bone still inside the skin, or is the skin broke the skin? The bone broke the layer of skin open. Well, why would you guys think that that's a big concern for us? Bleeding and infection's the big one. So if it's open, there's a lot of they call it debriding and cleaning that has to go into it to get that wound clean again. So green stick is an incomplete one, and then angulated is bent at an angle. So that would be an angulated one. So it's bent to the side. But and that's a closed one though, right? The bone, when you can see it, definitely a prominence against the skin, but it has not broken the skin yet. Dislocation is a coming apart of the joint. So what's usually tore with a dislocation? Ligament or a tendon. So usually you get both of them, but a lot of times the injury is more of a ligament because you've lost that support and strength of it. And I guess you shouldn't, I mean, you can have a dislocation without doing it, but you usually will cause some strain and sprain with it too. But it's usually the ligaments that, after so many times of dislocating it, you stretch those to where you no longer have the strength in them. So sprain is a stretching or tearing of the ligaments. And then the strain is the overstretching or overexertion of the muscle. Some things though to consider for us though, not all injuries can be confirmed as a fracture in the field. We don't have x-ray. So what treat all signs, I was going to ask you that, but it's the next point. But treat all signs of injuries and symptoms as a fracture until proven otherwise. So we're going to, if we need to do a traction splint or just splinting itself, traction splint should only be applied to a suspected femur fracture. I'm going to leave it at that because there is one other place you could potentially, but for now, for the purposes of the test, it's a femur fracture. How would you guys, I can't remember if these slides, so some hallmark signs of the femur fracture. The foot, whatever affected foot is, will be, if you're laying flat on your back and your foot's usually straight up and down, right? It will always bend out, and then be an inch to two shorter than the unaffected leg. And then they're also just painful. So the foot will always be bent out, and the affected foot will always be 1 to 2 inches shorter than the unaffected foot. And then the splinting too, it's also comfort, but the big one for me, that why we do it is comfort. Patients will always tolerate a fracture a lot better if you can splint it really well. But the other part is too, is if we can stop that bone from moving, we stop the blood loss too, because the clots can clot up over that bone and stop the bleeding there. But if it's constantly moving, it's just like you guys sitting there picking a scab. It'll never stop bleeding because we never allow it time to stop. So for these though, we're going to have to rapidly identify and treat any life-threatening conditions. With a musculoskeletal injury, really the only big one that's we really worry about as far as a life threat with musculoskeletal injury is the femur. Be alert for injuries besides the grotesque wound. The grotesque wound is a distracting injury. You'll see that in test questions sometimes too. A lot of the times those gruesome, grotesque wounds, are they usually bleeding a ton though? Not usually. Like road rash is going to hurt and it looks cool, but it's not going to kill them. A laceration or their breathing problems, something like that. Cut or remove patient's clothing to complete the examination according to the environment and severity of the situation. So if we have somebody that we're pulling off the mountain with a musculoskeletal injury, when do we want to finish cutting those clothes off? Back of the rig. Yeah, we want to make sure they're well, and just even warmth on that one. But the privacy one, the other one I was going to give you an example of is, so we're over at the high school, injured football player or injured basketball player. It's the same thing there, back of the rig, just the privacy. Now, if we're out on a wreck on the road and it's, I mean, they're having breathing issues, whatever, privacy kind of goes out the door. I mean, if you can get somebody to hold up a blanket, a firefighter, cop, whatever, to kind of provide some of that. But if they're in a serious situation, clothes have got to come off. Okay? For a trauma scenario, I mean, it depends on the severity of the situation. But a lot of the times, the hospital, you've not completed your trauma session assessment until the patients have all their clothing removed, especially if they have a distracting or a painful injury like road rash or whatever. You guys will find a lot of the times when we go on the scene, they're going to be complaining of pain in the road rash, but that's not the severe injury. But that's what hurts. You know, you've ripped all those nerve endings off, screaming with pain there when they're bleeding to death somewhere else or something like that. So don't get caught up with those distracting injuries. Compartment syndrome can result in swelling in extremity as a result of a fracture. So your femur, for me, this is a big one right there. So let's say you get crushed on it and all of a sudden it starts swelling and swelling. Well, there's only so much that it can swell before we start cutting off nerve ending, bleeding, and you're just going to cause a compartment syndrome. And then once we relieve that, or, you know, it can't perfuse against that pressure. So then what happens to all the junk that's supposed to be coming back to the body to get rid of it? It just keeps building up. So we build up acid, we build up lots of nasty, nasty stuff in there. And if we can't get blood flow restored to it fairly quickly, you can lose a limb over it if it's not relieved. Is there anything we can do for that in the field? Splint it, try and get movement, and then just get them. You're not staying and playing with one of those. They're gone. So patient assessment, we're looking for pain and tenderness. The one that I like, and I don't think it does it. No. So you guys want to write this one down, we'll cover. This is an old acronym that I really like. It's called DCAP, BTLS. So the D stands for deformity. C is contusion. A is abrasions. P is for punctures. And then B is for bruising. L is for lacerations. And then T is for tenderness. And then S is swelling. And it's DCAP BTLS. It's basically what this is saying there, but it's, for me, it's a lot easier. Then I can just run down that when I'm doing a patient assessment on a patient. Oh, DCAP BTLS and deformities, contusions, abrasions, punctures, tenderness, lacerations, and swelling. But the other ones that they talk here too is grading or crepitus. So if you guys ever shot a deer, and that when you go around the shot and you kind of move the bones, you can kind of hear and feel that. That's what crepitus is. It kind of feels like bone and grinding on each other. It's cool in an animal. It's not so cool to hear in a person. I mean, there's some good musculoskeletal damage done with that. We're going to look for exposed bones. We've already talked on that with the infection. So if you guys find an exposed bone, dry, sterile dressing, and then wrap it. It'll also help a lot with the pain on the patient because that exposed bone end has a lot of nerve endings and is really, really painful. I mean, even just a slight breeze makes it hurt. Joints that are locked into position, especially the elbow. They call it nurse's elbow for whatever reason, but kids a lot of times it'll lock their elbow in. The scary part with it is you lose circulation and stuff to the hand. So sometimes a doctor, an ER doc, if he knows you and is comfortable with it, he'll ask you to set it. A lot of the times they'll take it over and they don't even take them off the gurney before they do what they need to pop it back into place. And then nerve and blood vessel compromise. So that's a lot of your swelling, tenderness there that we're looking for with it. So they went to the 6 P's of an assessment. So the pain and tenderness, pallor. We're looking at the skin color. For me, that always goes back to shock though. On the parathenesis or parathis, I'm not even, the pins and needles. So that they feel the pins and needle, that's just a sign of nerve damage and swelling too. Pulse diminished or absent. So one of the things that we'll hammer on you guys on your trauma assessments and bleeding and blood or bandaging and splinting is you always have to assess a pulse before and after we do anything. That kills you guys. So many guys on the test, they'll do it first, but never remember to check it afterwards. Paralysis and then any pressure. So patient care, we've already hit on a lot of this. Take standard precautions, PPE, your gloves, things like that. Perform a primary assessment, make sure we don't have any life-threatening injuries, whether it's bleeding, airway or whatever. Apply a cervical collar if you suspect spinal injury. That one is really going away though. So when you guys get in the field, in the book, so the tests are always a year or two behind what really goes into practice. We used to see collar and backboard everybody, and that is going away really. The backboard is becoming a moving device, not anything else. Splint any suspected extremity or fractures after treat the life-threatening, and then cover open wounds with a sterile dressing. And it needs to be dry. So some splinting, some advantage of it, we've already talked in it, it minimizes the movement or disruption of the bone ends, decreases pain because we're not sitting there rubbing those exposed bone ends, prevents additional injury to soft tissue, and then can prevent a closed fracture from becoming an open, and then minimizes blood loss. So realignment of an extremity, assess the restoring effective circulation to the extremity and to the splint, and to simplify splinting. So what that means is, we'll touch this next part, and the next slide goes over it. We'll kind of talk in it. If not realigned, splinting may be difficult or ineffective, causing increased pain and possible further injury. That being said, we're going to here. So that's your nurse's elbow that they're trying to reset right there. Let the patient say where it's a position of comfort for them. Try and splint around it. If we're in the field, you get one chance. If we don't have a pulse, you get one chance to try and realign that bone to get those arteries and veins going. Before you do that, if at all possible, let the advance get some pain meds on board, because they'll actually, their muscle contractions and all that are a lot. It's easier to set a muscle if you can get some pain management on, because it relaxes. So you're not trying to pull against these large muscle groups. On that, and this is just a deformed extremity. So I guess let's back up and cover that too. So if you have somebody that just has a broken arm and it's just a little bit that way, still have a good pulse, we still have all of that. That's not what they're talking. They're talking on these. If you have an arm clear, obvious deformed, way out of proportion, we don't have a pulse, we don't have sensation or motor there, we're losing color and things in it, that's when we're going to try and realign this deformed bone. Increased pain is only momentary. Bullshit. Sorry. I guess in the scheme of things, it is only momentary, but it is really painful, and it takes a little bit of time for that to go down. And the whole time, once you've realigned that, if they're in a lot of pain, their muscles sit there and spasm, and you're literally fighting against those muscles the whole time to hold it in place. So splint in the position found, that's what we're talking, unless the distal extremity is cyanotic or lacks a pulse. If we have a pulse and they can feel you're doing it, we're just going to ask them what is the most position of comfort. Most of the time you find they want to hold their arm to their side, and that's where they're going to want comfort. So we're going to splint it right there. On the legs, the same way. I want it straight up and out. So just whatever's position of comfort for them. If the extremity is cyanotic or lacks a pulse, align the joint to neutral position using gentle traction. And when they say gentle traction, it's not like, okay, we're just going to slowly pull. What we mean is I'm not going to grab onto your arm and, okay. It's going to take some force, so it'll take a lot of pull, but it's going to be slow, steady, gentle pressure. Okay, we're not going to, you're going to put a lot of pressure on it, but we're not going to go from 0 PSI pressure to 150 right now. Just work your way up gently until you get that bone to slap back into place. If it's an arm, the distal extremity, or a lower leg, have one person hold the joint above it, try and give you something to pull against too. And then we're going to do it in the direction of where it should be in it. So when they're saying traction in the direction of long axis of extremity is a really good way of saying we're going to pull where it should be in an anatomical position. So if the arm's out here, I'm not going to, if my right arm's bent out to the right, I'm not going to keep pulling it to the right. I'm going to pull it back to the left, trying to bring it back into an anatomical position. If no resistance is felt, maintain gentle traction until the extremity is properly aligned and splinted. So effective splinting may require some ingenuity. Splinting really is, so we're going to talk about it here in a minute, but it's whatever you have to do. So if we have a broken joint, I got to get the bone above and below it mobilized so it can't move. If I have a broken bone, then I got to get the joint above and below it immobilized so it can't move. I don't care how you do that. I mean, in the mine, we've used hydraulic buckets and scoop tractors and blankets and garbage bags, and we call it foam for our stoppings and stuffed around guys. I don't care. You just got to get those bones mobilized. For us in the field, though, when you guys start running with an ambulance, we have 3 different types. You have rigid strip splints. That's your backboard and things like that. Formable splints would be your air splints or vacuum splints. And then your traction splints will be your femur traction. So there's your guys' stop. The ones on the top left, those are your traction splints. My gosh. The backboard is your rigid, and then the far right is your formable ones. 99% of the time, those are what we're going to use. They are so freaking nice, those vacuum splints. So what they are is they're just a bag full of little BBs, and you form it to whatever you need that to look like for the patient, filling in voids with it. You suck the air out, and it goes solid as a rock. So most of the ER staff knows it now, but don't let them cut that. They're going to regret it just as much as you are, because they're all of a sudden they have thousands of BBs on their floor they're walking on. Not that I've ever seen that happen before, but don't let them cut it. Okay, it's a mess. Strategies. We're going to go over all of this for when we do the hands-on, guys. So I am not going to spend a lot of time on strategies for it. Other than with splinting, maybe I'll see if Altalyn can come over one day and help us with splinting. She's great. Pad those voids. If there's a void on the backboard, or if we're doing a rigid splint or whatever, take towels, take pillowcases, whatever you can in the ambulance, or blankets, and just start filling those voids before we suck them up in that. They're going to be a lot more comfortable. Splinting a patient to death, this is the same thing. Is a broken arm or bone going to kill them? No. I mean, a femur potentially could, but other than that, no. So we got to make sure we're still doing our ABCs. Then some other hazards with it is we do it too tight. So we compress the soft tissue and we can create our own compartment syndrome. So that's why we check the pulse before and after, so we make sure we didn't get it too tight. Far too often though, what happens is it's too loose. And so now we're allowing movement, and the idea we're doing to stop the bleeding and doing all that, and just sat there rubbing. So a lot of times it's not necessarily that it's too loose as much as we have too many voids. So if you have a big void, it's hard to suck the splint around it because there's nothing to hold it in place, so that bone can sit there and move. So it's a combination of too loose and too many voids most of the time is the deficiencies that we see. And then splinting in a deformed position, if that's the only way you can get it, and you can't get the gentle traction on it in one time, then you're going to have to splint the way it is and get going. But just be aware that it's going to take some ingenuity and some diesel fuel, because they need to get someplace where they can get some pain management and things that way too. Take appropriate standard precautions, if possible. And most places and hospitals now say, not even if possible, you have to expose the splinted area. We don't want clothing, jewelry, anything like that between the skin and the splint, because you can cause other issues that way too. And then also, if you have clothing or jewelry in between there, they can x-ray it now without taking it all off, pulling that all off, re-splinting it, re-x-ray it, and then they can x-ray it. So anytime you're splinting, nothing between the splint and the skin. Manually stabilize the injury site. We're going to go over some tips and tricks like this one. The EMT's doing that a lot of the times. Let the patient do that. Give them something to do. And are they going to move and do something that makes them hurt? No. Can we and do we often move them unintentionally and make them hurt? So if they can help you with it, let them hold them in place. You know, if they have a broken arm, this one's showing like they have a broken arm, let her take her left arm and hold her right in place, and she's going to hold it and not move it to cause any pain. Or you and I, if we turn and look for something, you can move that. So yeah, so let them do it. Let them help you. We're going to go over all this stuff in class. So some specific injuries though: shoulder girdle injuries, pain in the shoulder, drop shoulder, severe blow to the back or scapula. For us at the mine though too, so sometimes these guys, if they've been roof bolting all day and all of a sudden they can pop their shoulder out, they can get pain in it that way. But those are the things we're looking for: pain or tenderness upon touching. And a drop shoulder just means you're comparing the left to the right, and if one of them's dropped down, obviously we've had some tissue or bone damage to allow that scapula to come either raise out of place or drop where it shouldn't be. So for them, we're going to assess the distal CSM, circulation, sensory, and motor is what the CSM stands for. We're going to use a sling and sloth, which we'll show you guys. If evidence of anterior dislocation of the humerus, place a pillow between the patient's arm and chest. If you have a broken humerus and you just shove it tight to them without that, it actually can take that humerus and bend it out. So you want to just make like a triangle underneath them so that holds that humerus in place. You guys will see that too a lot of times with shoulder surgery, so it doesn't sit there, pop that shoulder out. When they splint it, they've got a big triangle that goes underneath it to hold that in place. So we're going to do the same thing. Do not attempt to straighten or reduce it. There's no way really to reduce your shoulder. And then reassess distal location after we've done the sling and swap. Pelvic injuries, so that's your hip, right? Or your hip goes into your pelvis. Usually what age group and sex do we see this in? Older females that have went through osteoporosis. You'll see this a lot with them. Pain in the pelvis, hip or groin or back. Pain when pressure is applied to the iliac crest. You guys know what that is? So the iliac crest, if you guys feel just below your belly, it's the top of your pelvis, those bones that you feel there. That's your iliac crest. So we're going to put gentle pressure on that. We're going to do a little gentle pressure down, a little gentle pressure in. If they have any, I promise you, with every broken hip, All I've done is one of them, and I barely touched that iliac crest, and they're screaming out. So if I do that from touching it, do I need to push in on it too? No. Okay. If just touching it and they're screaming at me, I'm going to go with it's broken. We're going to splint it. It's pain management, and we're gone. Okay. They cannot lift their legs when lying supine. Lateral rotation of the foot. The difference between it and the femur fracture is, so a femur usually goes out and then shorter. With the pelvic fracture, it goes out, bends out to the lateral, but it doesn't get shorter. Because you've still lost that integrity of the bone to hold it in place, but we haven't shortened it. It's just now these great big muscles along the thigh here and pull that sideways without the pelvis doing that. Unexplained pressure in the bladder, bleeding from urethra, rectum, or vaginal opening as well. Usually the bleeding from the urethra or rectum is a later sign, but unfortunately you'll see that a lot of the times, because what happens with these guys, a lot of the times what you find is they're getting up out of bed and all they do is twist to go, you stand in bed and they twist to start walking. Well, the one foot doesn't twist. And then they'll lay there all night until somebody comes in to find them. And then you can see the bleeding in the urethra and their urine a lot of the times too. So move these guys as little as possible. Have a plan. We're going to go over some pelvic binders with you guys that really help. We're going to try and stabilize and straighten those, get them in a anatomical position and stabilize them. And then assume spinal injuries. We assume it, but the best thing for these, and they call it those vacuum splints we talked about. We call them a body splint. It's literally 6.5 feet long, one of those, and you can fold it all around them. You can use it to hold the limbs. You can use it to kind of help hold pelvic pressure, and then suck that down, and it just kind of sucks them into it. And you'll see it in these patients' face, just the relief of that actually going around and sucking tight around the pelvis. And then you don't move them very often. Okay? After we're done with that, we're going to reassess the distal CSM, care for shock, high concentration, transport the patient as soon as possible, monitor ALS. Pain management for all of these is huge, and the patients just do better. Pelvic crack, you can also use your sheet. We're going to go over all of this. There's a commercial one that I have that we'll show you guys. And then Sam makes one too. But we'll go over the sheet and then how to do all of that. But like this picture, they are nowhere near her pelvis or her hip. So, I mean, they're showing you that because you have to be careful, like with this little old lady, if they did it and kind of think that you might actually could create a pelvis fracture, which is why they're doing it here. But I just don't want you guys looking at that and saying, well, the book showed it down lower. No, it's got to be over the pelvis. It can't be down around the femurs. Okay. Oh. So hip dislocation, you have the anterior or posterior. The leg for those guys is bent inward and the knee is bent. Okay. And then they have the lack of sensation in the leg. Sorry, just a second. I'm getting a call for the line. Lack of sensation in the limb, so they don't not feel it, but it's just, have you guys ever, when you sit too long and your leg kind of goes to sleep and it's like, I know it's there, but I can't really feel it? That's the way they'll describe it a lot of the times. So for these guys, we're going to assess the distal CSM, move them onto a long spine board, erase that. We're going to move them onto a body splint. We're going to mobilize the limb with pillows and blankets. This is one of the ones with their knee. We're not going to straighten it back out because it's not going to do any good. So we're going to put a pillow underneath their knee wrap them around with that knee in that position, because most of the time it's there too, because that's the position of comfort. Reassess distal, care for shock, transport and monitor vitals. And we're going to check the nerve and circulation and movement. But I will tell you too, guys, I've only done it down here once, but in Wyoming, we responded that we had an elderly population, and get your paramedic units there. We can do ketamine and fentanyl. And when they're ready, by the time, if I can pre-dose them before we hit the hospital, like I had a lot of the times with my docs up there in Wyoming, they're like, yeah, she had ketamine and fentanyl 20 minutes ago or 5 minutes ago, just before we got here. He said, oh, great. He just reached over and popped it back in. Pain's done. We're gone. Go x-ray it and see if it's in place. So if you guys can get a paramedic unit, we can help move that process along. And we didn't even move them off of our doc did that. We moved them from our gurney to the x-ray table, and then the x-ray table on the hospital. So it just works slick. Older adults, we've already hit on this, are more susceptible to hip fractures because of brittle bones and weakness from various diseases, especially female with the hip and pelvis. That's not to say we can't get a male with it, but females, especially post-menopause with osteoporosis, are far more susceptible to it. I don't know why we're doing this. Here we already hit on it. Anyway, pain is localized. It's usually right there in the hip, sensitive to pressure, or on the greater trochanter, so that's the top of the hip, so that top of the femur, excuse me. When you push on that, is when it hurts. Surrounding tissue is discolored, so you'll get the bruising. I don't know why we can't use bruising, but it's discolored. Swelling usually will be evident. They're going to be unable to move the limb while on the back. They're also unable to stand, right? They can't put any weight on it. Foot's injured. The foot on the injured side turns outward, and the limb appears short. That's a femur fracture. Because it just said hip fracture, hip dislocation. Okay. That's why we're talking about it again. They messed up on the slides. So we're going to place, fold the blanket between the patient's legs, bind them together with wide cravats. Use the thin splints to push the cravats and straps under place. Yeah, above and below the knee and at the ankle. No, because they're your femur. So why are we talking hip like that? Well, a hip fracture and a femur fracture are pretty well the same thing, right? That femur is not where it's supposed to be, so that's why it's turning that way. I just usually on a hip fracture, you don't see that limb. It doesn't. If it is shorter, it's not usually obviously shorter, like the femur fracture is. So femoral shaft fracture or femur fracture, they're in intense pain. If they're an open fracture, they had a significant, it takes a significant amount of force to break the femur. B, it takes even more force to have that sharp end come through the skin. So if you see an open femur fracture, just know the mechanism of injury, the energy that hit him was pretty substantial. The injured limb may be shortened. The only reason why it wouldn't be is if you have an incomplete fracture. It's still going to be painful, but what we're going to want to do is splint it in place. Not necessarily a traction splint. If you do light traction, so you don't want to pull it, make a complete femur fracture, but we're going to want to splint that and try not to move that leg as much as possible, because we want to keep it together and keep it an incomplete and not create a complete fracture. To control the bleeding, what they're talking is that if it was an open fracture and we have bleeding coming out of that open wound, we're going to apply a pressure dressing and stuff to that with it. Treat for shock, assess CSM, your sensory, motor, and circulation, or circulation, sensory, motor, however you put it. Apply a traction splint, which we'll show you in class, and then reassess the pistol pulses. Pediatric note, what's really cool, we use them at mine now too, as well as at your local services. We have, they call them a tent pole traction splint that we'll go over. Really, really cool because you can size them for pediatric or adult. If a pediatric breaks his femur though, that's even, I just can't put this enough. That is even more force because a femur or child bones are fairly malleable, and you know what I mean, until they get older. So if we're dealing with a 10, 12-year-old or even younger that has a femur fracture, those kids took a significant direct hit. I promise you. But apply the appropriate size splint to them. Knee injuries, they are painful, and tender. You'll get the swelling and with the deformities. Assess distal pulse, immobilize in the current position, or the test questions a lot of the time will say position of comfort, and reassess your pulses and sensories. It's the same thing with the tib fib fracture. So I can tell you when I did mine, it hurt bad. So you're going to assess for that pain and tenderness. Swelling, possible deformities, which you'll see on it. Apply a vacuum or an air inflated splint. Same thing, we'll go over those two. Immobilize the fracture using 2 rigid splint boards. So that's what we go over. The SAM splints is what we teach. Or you can apply a single splint with an ankle hitch. And we'll show you all of those. Ankle or foot, pain, swelling, and deformity. Same thing, always on all of these. We're going to assess the CSM, stabilize the limb, lift it, place cravats under the ankle, and then lower the limb onto a pillow, and then tie the pillow around the ankle. For whatever reason, just doing, well, not for whatever reason, if you elevate it just a little above the other, it makes it to where all the blood flow doesn't want to run down there, because usually you're setting down. So if you can elevate it just a little, it helps keep so they don't get the pressure from bleeding. Elevate with a second pillow or blanket, care for shock, and apply a cold pack as needed. So wrist, forearm, and hand injuries. The forearm, you'll have the deformities in all of them. I mean, it's deformity, which is why we stress doing so many patient assessments, because I don't care if you know what normal or what a deformity is. I just want you guys to know what normal is. So when we're doing these assessments, when you find a deformity, you go, oh, that's not how that's supposed to be. I don't care if you know if it's an open or a closed, or a complete or a green stick or whatever. I don't care. Even in the forearm, if you know if it's the ulna or radii, I don't care. I just want you to know that that's not right, and that's not how it's supposed to go. Fingers are really nice. Just use the unaffected finger next to it, and we're going to splint to it. Any questions on that one? A lot of that with the splinting is in class. So you guys will be very proficient at splinting by the time we're done. All right, guys, give me 5 minutes. So we'll start 7:05. Let me get the next set of slides pulled up. All right, guys, we'll get started again. So are you guys seeing chapter 33 out in Zoom land? We're gonna go with yes. If not, holler and I'll reshare it.
I can see it.
Yeah, we're seeing.
Perfect. So we're going to cover the nervous and skeletal system here, injuries to the skull and brain, wounds to the neck, and injuries to the spine. So the nervous system controls thoughts, sensations, and motor functions. It has two subdivisions. The CNS, or the central nervous system, consists of the brain and spinal cord. And the peripheral nervous system consists of the vertebrae, cranial nerves, and motor sensory nerves. The thing with the central nervous, the CNS part of it, is it's all contained in the skull and at the base of the skull. So it's really susceptible to swelling or injury that way. The peripheral nervous is too, but it has more area for that swelling to go without causing a lot of damage. The neurons are specialized cells that transmit the impulse through the body. And if you guys picture them, and I think the book shows them, or some of them do, but it just two elongated nerves, and you have the synapses between them, and so you have the touch between them. Which is where when we rip that, and all of a sudden you have that exposed end, so it's sitting there getting fired all the time. So there's a picture of it. So sensory nerves carry messages from the body to the brain. Motor nerves carry messages from the brain to the body. Motor neural messages control voluntary and involuntary. It still has that same, but it's not a motor nerve. And then the motor nerves cross the opposite side of the body. So the left part of the brain is controlling the right part of the body. It's the same as strokes. So it does the same thing that way. Nerves of the autonomic nervous system control the involuntary functions. So some anatomy part of it. The skull is made up of the cranium, facial bones. So the cranium contains, that's where your brain sits in, right? So you have the frontal bones, which is your forehead, the parietal bones, and then the temporal bones and the occipital bones. They kind of come around it that way. You guys don't need to know them. I promise you, you're good. Okay. Facial bones include the mandible, maxilla, nasal bones, molars, and orbits. Most cranial and facial bones are immovable joints. So the only time they're not is in a child, those plates will fold over each other. All those, the parietal, the frontal, the temporal fold over. And then as they get older, then the cartilage hardens and then they're in the whole joint. The mandible joins the skull at the temporal bone, so down right here on the side of just in front of your ear, at the temporal bone, and this forms the movable temporal mandible joint. You'll also see that TMJ. I do not know why, but some test questions will call it the TMJ joint. And there's some people that it's nice when you have to wear that shit. I can say that. The brain is held within the skull or the cranium. It exits through the spinal cord, exits through the base of the brain, leaves the skull through the foramen magnum. If you guys really want to know, there's 12 different cranial nerves, and they all have their own hole or magnum that they go through. The big one for you guys, though, is the base of the skull is where the spinal cord comes through. Cerebral spinal fluid is what bathes it. It's the lubrication nutrients that go around the spinal cord, the brain, all of that. Okay, and it's supposed to be contained, meaning it's not supposed to be able to leak into your ears or nose, which is, we'll talk here in just a second on when we do the patient assessment for head and neck injury. And things, so there's your temporal bones, your parietal bones, kind of the top, back of your head, and the occipital is the base at the back of your skull. And kind of some self-explanatory there. It's the spinal cord is the main pathway for nervous, and then it branches out to carry messages. Where does it usually branch out at? The spinal cord goes down and then it kind of trees out, goes through in between the vertebrae. The pieces of it go out into different parts of the body. It's a tough fibrous meninges around the spinal cord and inside the spinal column. It's the same thing. It kind of it's a protective barrier, which is great because it's, in theory, it's not supposed to let anything get into the spinal column and into the brain, but also it doesn't let a lot of medications go through too. So if we get an infection in there, it's harder to fight because that is a barrier and won't let it through. Spinal column is made up of 33 vertebrae. They're stacked one on top of each other and interlocking with the tendons and ligaments support by the back muscle. And then every vertebrae has a donut hole that allows the spinal column to run through. The further down you get, so when you start getting down into the coxal and sacral, it gets lower, smaller, smaller, smaller. And then the bone actually gets a little bigger and bigger and bigger because it's taking more weight. So cervical, you have 7 of those. The ones that we're going to go to this side because it shows it better. So cervical, you have 7 of them. The ones that we worry about are the atlas and the axis, and then also C3, because that's where the nerves come out of the spinal column that innervate into your diaphragm and make it to where you can breathe. If we get a spinal dissection in any one of those, the patient will stop breathing. So if we palpate the neck right at the base of the skull and they have tenderness and stuff there, that's when all of a sudden we're going to really pucker. We're going to do C-spine, put them in the body splint, and just try and do whatever movement we can, or prevent any movement we can. Scalp, excuse me, geez, not scapula. The scalp has a lot of blood vessels, so it bleeds profusely. Usually, though, we can do the direct pressure, loose gauze. If there's a possible, so direct pressure, if we suspect no skull injury or cranial injury, we're going to do direct pressure, and it usually stops it really well. The other thing why a scalp bleeds so bad is when a normal blood vessel bleeds, it retracts and it can pull that blood vessel in and make it, instead of a big garden hose, it can pull it down to a 1/4-inch hose, and then the clotting can do that. Well, your scalp has no way to really retract back. It doesn't have the big muscle grooves to pull back into it. So it has no way to shut off the bleeding on its own. So it bleeds a lot, but it's not necessarily a serious injury if we get the direct pressure and stop it quickly. If there's a possible skull injury, we're going to use loose gauze dressing instead of a direct pressure bandage. Skull injuries include facial and cranial fractures. So if we get hit hard in the face, where do these bones go in your face? Your cheek, if you get hit really, really hard on the cheek, where does it go? Straight back into your brain and can cause swelling. Same with the cranial nerve. If we get hit, or cranial fracture, if we get hit hard at the base or on the side, it goes right down against the brain. It's nice and protected, but once it starts to swell, it has no place to go. So we got to be really careful with those. Is there anything we can do to help prevent swelling in the field or stop it? Well, these guys need a trauma center, and they probably need a helicopter, because even Castle Valley, Sanpete Valley, even with all the amazing things they can do, they can't relieve that very well. Closed head injury occurs when the scalp is lacerated, but the cranial is intact, and an open occurs when the bones to the cranium or the face are fractured. Most of the time, it takes a fairly significant mechanism of injury to get an open head injury. Not that they don't happen, and not that I haven't seen them, but it takes a fairly large injury to do that. Your closed ones, it doesn't take a lot either. Okay. It is safest to assume an open head injury beneath any contusion or laceration of the scalp. It's the same thing. We don't have x-ray. We can't measure how much swelling is going on. So we just assume that that's what it is. Always suspect spine injury with brain or skull injury. The reason we suspect that, if we took a hard enough hit in either the face or the head, what does that do to your axis or atlas? So C1 and C2. You take a hit, it's going to stretch it way back or way forward, so you can tear that spine through there too. Just because your head, I mean, it's great, we can move it side to side, but you get a hard hit and also can pull off of that. So there's your open skull fracture. So a direct injury occurs when the brain is lacerated, punctured, or bruised by a broken bone or foreign object. Indirect is the shock of the impact from the brain. So that's your concussion and contusions. Or the injury you'll see them is that coup contra coup, meaning the brain. You get hit in the skull, it doesn't fracture the bone, but the brain's still bathed in this nice fluid. So what does the brain do? Hits against the side and then comes back and hits against it. So we can get some swelling that way. With your concussions or contusions is what the injury is called. But the mechanism is that contra coup, is the brain hits the solid skull and bounces off of it. Traumatic brain injury disrupts the normal functioning of the brain and may be brief or long term. And the severity of that depends on the mechanism of injury and how long before that swelling could be removed. So a concussion occurs when the head is struck and the force is transferred to the brain. Should be taken serious even with mild symptoms. Contusion is a bruised brain with enough force to rupture those blood vessels. And there's your coup contra coup that we talked about. And there's your picture of it too. So the initial force was to the front of it. The brain goes back, impacts the back of the skull, then rebounds and comes back and hits the front of it again for your coup contra coup. So a traumatic brain injury also disrupts the normal function of the brain, maybe brief or long term. So the laceration or cut of the brain. So this is, now we're talking about an open skull fracture, an open fracture. So that's the laceration is a cut that's caused by the same forces that cause the contusion. So whatever punctured the brain hard enough lacerated that and go into the brain. What usually gets these guys in trouble is these hematomas. It's a collection of blood within the brain tissue. It's great. The brain's surrounded in these nice sacs for all of that. Provides a lot of fluid, but it doesn't allow for any swelling. So you have a subdural bleed, which between the brain and the dura mater on the brain. An epidural is between the dura and the skull. And then an intracerebral is when blood pools within the brain. So if you guys look at this picture here on the far left, the dura is still pushed against the skull. So you got blood between, and the dura is just a sac or a membrane that goes around the brain. So it's pushing the brain, just the brain to the side. The middle one, it's between the skull and that dura. I mean, they both still push pressure, but it's just where at. And then your intracranial is just a generalized bleed across the large area of the brain. Does it matter for your guys? You guys need to know whether it's, when you're treating a patient, does it matter whether it's subdural, epidural, or intracerebral for what you're going to do? No. Just know that there are 3 different types. As the hematoma develops, the ICP or intracranial pressure increases inside the skull. And the more it compresses and progresses, then we start to see neurological abnormalities that develop. Causes the brain to kind of push through that small opening in the bottom. And it's big, obviously, foramen magnum is large. But it's trying to push. That being said, it's not large enough for the brain to go down through that hole in the bottom of the skull. So we're starting to push it that way. The time it takes for symptoms to develop depends on the rate of bleeding into the skull and the location of the bleed. The 3 that I've seen, We had one that it was just slowly kind of showing stroke symptoms. And I had one that when we got on scene, it was obvious open head fracture, obvious abnormalities. He passed away 6 months later. The other one, they were able to relieve it. When ICP increases the blood pressure, increases to pump blood into and perfuse the brain. So it's trying to, the brain saying, I'm not getting oxygen, I'm not getting blood. So what's its response, the body's response? We're going to send more and we're going to pump more. What does that do to the pressure in the brain? It increases. So once it gets to a certain rate, though, the heart rate may slow down. They call it the vagal nerve compression, as it pushes down there hard enough. They vagal out. You'll find a lot of little older people in the toilet that they bear down and they vagal out that way and pass out. You can get the same thing with this. Rising blood pressure and slowing heart rate together is known as the Cushing's reflex. I don't know if you'll see that necessarily on the basic, but we focus a lot of that on when we do the advanced. You don't want to see those things start to come together. So, or excuse me, get farther apart. So we don't want to see the blood pressure rising and the heart rate slowing and slowing and slowing. It's called the Cushing's reflex. And then it's the same thing though, we can't perfuse it. So carbon dioxide levels increase and then the brain tissues swell because they can't get rid of that. So now we've got bleeding. Now we've got the brain cells themselves trying to swell to get rid of it. It's just, it really is a domino effect, I guess, and it just progressively gets worse if we don't get treated right. So some other things that you guys are going to see as that compressions begin with their breathing, they're going to be tachypnea, meaning they're breathing slow or fast. Tachy is fast. Okay, so they're going to at first they're going to start to breathe faster and faster. It's the same thing. The brain's saying, "Hey, you got to get rid of this carbon dioxide." So it increases the heart rate, increases the blood pressure, and increases the breathing, trying to get rid of it. Then we'll go to the Cheyne-Stokes breathing. And we'll YouTube it. When we start doing the patient assessments, we'll YouTube a lot of these breathing and heart sounds just to let you guys hear them. And then central neurologic hyperventilation. And then ataxic means without, so they just stop breathing and respirating. As the brain herniates, okay, so decoritate and decerebrate posturing may occur. So I don't know how to show you guys. Jessica and Will, we'll probably have to show you that too in class because there's no way to show you that really well. If you guys look in the book, it has it too. So they'll usually go. At first, they go out like this, so they'll kind of posture out, and then as it increases, you'll watch their hand and arms, they come up in. It looks like a praying mantis. I saw that same thing. We watched her in the car in the canyon, and went from this to all of a sudden like this, like 40 minutes in the hospital, and she passed away. It was fairly quick. But she took a pretty significant hit to the head. Same thing, those signs and symptoms of rising may be immediate or delayed, and it goes back to the same thing, the amount of bleeding and swelling and how fast it's happening. So if it's immediate, you have a pretty significant bleed and swelling going on. If it's delayed, you have a smaller bleed. Does that mean that we don't still need to get that relieved? I mean, they still need to get flown, they still need to get that done. But we don't, it's not going to kill them in the next 20 minutes usually. Now they may have some long-term side effects from it, but it's not going to kill them. So some other signs and symptoms you guys will see: visible bone fragments, brain tissue, altered mental status. And so when we say, I mean, if you're seeing bone fragments and brain tissue, you're already way behind the curve here. So if you're seeing some of that, I mean, I would hope you guys would know that, yeah, that's an obvious skull fracture. But anyway, Deep laceration or severe bruising or hematoma on the scalp or forehead. The big one that you'll see usually with it is you'll have a depression or deformity or swelling on the skull. You very, very rarely will see brain tissue. And usually if you do in bone fragments, it's usually a fatality. If they've taken a hit that hard, game over. Severe pain at the injury site, bruising and battle or behind the ear. So they call it battle signs. Usually it's the same thing. If you get on scene and you look behind the ear and there's bruising, and it's been 10 minutes after the wreck, that's a significant injury. But if you see it a lot of the times, like the next day, if somebody took a pretty significant hit to the head and got a good contusion or whatever, you can see battle signs. Pupils are unequal or unreacted to light. So you'll shine your light in there and one will be blown or big and dilated, and one will be pinpointed, and neither one of them will respond to our light. Raccoon eyes or black eyes, discoloration soft underneath both eyes. It's different in the black eye. Usually if you get punched in the eye, you'll get one. The raccoon signs, you'll get in both, and they'll be big black. Yeah, same thing. It appears fast onset versus slower. One eye appears to be sunken. It's the same thing. We've either took a pretty good significant to that orbit or that orbital socket, and the eyes is this full of vitreous fluid that we talked about when you get an injury to it. The same thing, it got hit and all of a sudden it just ruptured that eye. And if we've got a hit hard enough to rupture the eye, there's also, I promise you, there'll be some orbital socket damage too. Personality change. Oh, blood or clear fluid from the nose or ears. That's your cerebral spinal fluid. So you'll see CFS. You'll see that on it. It won't say blood or clear fluid. It'll say cerebral spinal fluid. That's what you're looking at. We'll show you. There's some pictures on it. I wish they had showed it in the slides, but the haloing effect. So you take a piece of gauze and you tap it to wherever that clear fluid is, whether it's in the ears or the nose, and then just let it lay flat. It'll create a circle around the liquid or a halo. And if you see that halo on the gauze, it's a positive indication of the cerebral spinal fluid. The increased blood pressure and pulse rate, or the Cushing's that we talked about already, irregular breathing patterns, and blurred or multiple image vision. Some other things with it: impaired hearing or ringing in the ears, equilibrium problems. What does that mean? Yeah, they're balanced. You're not going to be able to walk. Forceful or projectile vomiting. That's always fun. The quartet or decerebrate posturing. We'll show you that in class. Seizures, temperature increase, and deteriorating vital signs. The seizures, temperature increases, and deteriorating vital signs, that's a late sign. You really got to get aggressive at that point. If there is shock with head injury in adult patients, we're going to look for blood loss elsewhere on the body. Assume a skull or brain injury when the MOI and location of the injury indicate a possibility. So what are we going to do about it? We're going to take your always standard precautions, meaning PPE or BSI. So you have your gloves. They have the potential for projectile vomiting. I would strongly suggest eyeglasses. Open and maintain an airway. The other thing you'll find, if they took a significant hit to the head, they get a lot of blood in the airway. So maintaining an airway is going to be really important with these guys. So suction, keep that airway open. Monitor unconscious patients for changing in breathing. So we're going to watch their chest really well. If indicated, apply a rigid cervical collar, control bleeding, and keep the patient at rest. We're going to, with a conscious patient, we're going to provide them emotional support, address any open wounds, and stabilize any penetrating objects. Manage the patient for shock, be prepared for vomiting. So what are we going to want to have out if we're going to prep for vomiting? Suction. Okay. Transport the patient promptly. They're we're not staying and playing, we're gone. And are they stable or unstable? Unstable, so every 5 minutes. So the Glasgow Como scale, I don't know. If you guys did this every day, you can remember that. I even struggle with GCS. A lot of the times on ambulances, it'll be on there, or the patient charts, it'll have it. So some things though that we'll look at with it. Are their eyes opening to either? So if I look at you and say, "Hey," and you look at me, one, you are responding to a verbal, but are you oriented? Meaning, if I say, "Hey," do you look at me or do you look over the left? Or excuse me, yeah. So just the eye opening. Are you looking at me, and is it appropriate? Verbal response. Are you oriented? Meaning, if I ask you, "Hey, where are you guys at?" At City Hall, right? Okay. And if I ask you where are you at, and you say India or whatever, okay, that's not oriented. Not a, and so they're more confused that way. Inappropriate words will be the same thing. If I ask you, "Hey, where are we at?" and you say red, like, okay, nope, that's not the appropriate response to that. Or if you just make incomprehensible sounds, or no verbal response at all. Motor response is if you obey commands. So if I can tell you, "Hey, lift up your hand," and you can do it. If I don't get any response from you without pain, without causing some kind of pain. So if I have to pinch your finger or pinch your arm, whatever, and you'll punch away from that, so you'll localize the pain. If you withdraw, so if I pinch your arm and all of a sudden you just keep pulling it away from me, then you're withdrawing from painful stimulation. Or if all of a sudden I pinch it and all of a sudden you posture, meaning we do like your hands and stuff will come up to your chest and your posture, or guarding sometimes is the other word they'll go for it. That's worse. We're moving down. Or if I pinch you, do a sternal rub and I get nothing, or even worse. Calculate the GCS score en route rather than spending the time on the scene. And a lot of the times you're not going to calculate it until you do your report. But just know what we're looking for there. And you can tell the doctor, like, if you want. So they get a total of 12. And even a dead person gets 3. Okay. So you don't have to say you. It would be great if you could tell the hospital, like, "Oh yeah, they had a GCS of 12." But what, for me, what's more important, what a lot of the times the doctors care as well. If you say, "Well, I've got a GCS of 10." Well, why? He's only opening his eyes to voice, and he's confused when he answers. So he got deducted 2 points. Okay. So for that eye opening, if you're just spontaneous without having any stimulation at all, if you're opening it, you get a 4. If you respond to voice, if I say, "Hey," and you open your eyes, then you get a 3. If the only way you can open them is if I create some kind of a painful stimulus, you get a 2. And if you get nothing, you still get a 1. Then your verbal is the same thing. If you can talk to me, if I can answer your questions, you're oriented, you get a 5. If you're confused, we deduct 1. Inappropriate words, we deduct 3. And incomprehensible sounds gets 2, and none gets 1. Motor response, if I can tell you, like we said, move your hand, you get 6. Localized pain, you get 5. 4 is if you withdraw. 3 is if you flex, or, well, they broke this down even more. So if you flex with pain, so which way is flex? Out or in? Out is flexion. And then if you come in, then you get a 2. That's extension to pain. And if you don't do anything, you still get 1. So even a dead person gets 3. What's that? A 12 is what we're looking for. Yeah. We're going to talk about impelled objects, stabilizing them in place. So we're not going to go over that. The only time that we will remove an impelled object is if it is in the airway. Otherwise, we leave it. So if it's obstructing the airway, we're going to prepare to remove it. But what also comes as soon as you pull that out? A lot of blood. So we're going to have to be ready to suction. Mandible of suspected dislocation, fracture, pain, swelling, facial distortion. The patient may not be able to move their jaw, have difficulty speaking, and show improper tooth alignment. We're going to go over that in class. So wounds to the neck, the big part with it is those large arteries and veins, right? If somebody gets their neck slit, they can bleed to death quickly because of those. Pressure in the large vein is usually lower than their atmospheric pressure, so even if it's a vein, it just wants to flow out. The other big part with it too, though, is if air gets sucked into there, and then we create an air embolism going into the brain. So we're gonna cover, yeah, and if it goes to it's the same thing. If an air embolism, the only difference between a stroke, heart attack, and pulmonary embolism is where the air ends up at. Okay. So it can lead to cardiac arrest too. Direct pressure is a life-saving step, controlling that hemorrhage. First priority is stop the bleeding. Second is preventing an embolus. Take care to avoid interfering with bleeding and applying pressure. So a lot of the times you don't want to put up flat. If you have those, you want to find where the bleed is and take your finger and just push on it. Okay. We'll talk about it too. Ensure the airway's open. Place a gloved hand over the wound. We're going to apply an occlusive dressing. So a lot of the times saran wrap, actually, all the ambulances carry that. We're going to take saran wrap and go around the neck just to prevent air from getting sucked into that wound. Immobilize the spine if MOI suggests cervical injury. Any questions on neck? A lot of the times, though, too, guys, if they have a serious bleed, even in best case scenario, what, 7 to 12 minutes out? That's usually a done game before we get there. If you get there and you have it, though, you better be freaking aggressive or it will be a done game. Fairly short, in short order. So injuries to the spine is any time those bones, ligaments are damaged, and spinal cord may also be damaged. And so some specific spinal column injuries is a fracture without bone displacement. So a lot of the times, if you get a hit and the bone stays in place, it just fractures, it causes some injuries, but it isn't as severe. Okay. The dislocation is if those two spinal vertebrae, one shifts from the other. What happens if you shift and that pulls too far, though? We're going to sever that spinal column. Muscle strains is the same thing. If those pull too hard, create a lot of pain, and you can break that or you can pull on that spinal column. And then disc injury, including compression. So that's whenever it says, oh, I blew a disc, what happens is that disc ruptures in between each one of those vertebrae. There's little bursts or discs that prevent, so it's not bone on bone. It's a lubricant for the bones to move. If you rupture those, it swells a lot of times into the spinal column. And then if it swells so much, then the electrical activity can't go past it. Any of these injuries can occur without cord damage, but the risk must always be taken into consideration. Okay. We've already talked on a lot of this. It can be lacerated, it can be contused or pinched. And pinched is just a fancy way of it's swollen so much and now it's just pinched against the back. The others, you'd say, oh, a lot of the times you hear somebody with a back injury say, oh, I just have a pinched nerve. And that's what they're talking about. So the primary injury occurs immediately due to the direct force. A lot of the times what we're dealing with those secondary injuries. They can cause a lot more harm than the primary injuries. A lot of the times if we have those free floating bone ends. We're going to want to get these guys laid down and stop them from moving. A lot of the times though, they want to lay down flat. Now, what does that do to all the weight of their torso? Put it straight on that. So a lot of the times they're going to want to set up, and that's fine. Are they going to want to take a good deep breath? So they're usually hypoxic and shock. So we're going to have to do treat them for shock and get them on oxygen. And then hypoglycemia can lead to devastating cord damage. Can it heal itself once it's severed? No. So we got to be really careful with that. And any damage that gets caused that way to it. That's why diabetics, a lot of times, they get that neuropathy and damage to it because they go low so often that it starts to cause damage to it. Assessments must account for the possibility of spinal or in any traumatic injury. Not every trauma patient has a spinal injury. 99% of them don't. Physical findings and MOI. What's MOI? What are they talking? Mechanism injury. Perfect. Is what we're going to have to take into effect with this. And then the patient's physical condition also is in count. So if let's say a 70-year-old gets hit with 5 pounds in their back versus a 25-year-old, is the chance of injury the same? No. Okay. If you get a 27-year-old that's skin and bones, and you get somebody that's obese and get hit, is the injury potential the same? No. Okay. So physical condition does play a huge part. So some other ones too, that we look at the force that goes behind it. It's anytime that it's injured beyond its normal range of motion. So can it flex and extend? Yeah, we can bend over and stuff. But what happens with the whiplash is that all of a sudden you get hit, and that motion all of a sudden you overextend it or you overflex it and cause damage. Over rotation is a twisting or sport injury. Compression, a lot of the times we say shallow or water diving. What other ones would cause a compression? The common one I've actually seen is the fall. If they fell and they hit their head straight or they hit straight on their butt, you can get that compression in it too. A distraction injury or a hanging injury. I've seen them, but never had to treat one. It's usually done by the time I've got the penetrating trauma to it, and then lateral bleeding or disc injury. The distraction for the hanging one, you see an obvious length. Cervical and lumbar vertebrae are the most susceptible. Why? Why are they so susceptible? It says they're not supported by other structures, right? So what other structures in the thorax support that? Your rib cage, right? Okay, up in the neck, is there any way to support it? And what does it have sitting on top of it? A big old head, so it's really susceptible that way. And then your lumbar ones, is there anything to support it once it goes below your rib cage? No. And what is it that it's holding? The whole upper, yeah. So it's really susceptible to that. We've already hit on osteoporosis in older adults. Ligament, elasticity in pregnant women and patients with Down syndrome. They're when you guys, especially in the last trimester, what happens to the ligaments and stuff in your pelvis? They start to loosen and stuff. So it doesn't just happen in the pelvis, though. You get it in all sorts of other places too. So when you get into that last trimester, you can have those problems too. Down syndrome patients have it all the time. If we get older and you have a fused vertebrae or fixed flexion deformities, and I'm not even going to say that. So if we fuse your vertebrae, can it take a hit very well at that point? No, it has nowhere to let that or that energy go, so it can be more susceptible to injury. Some other ones too: falls from greater than 3 feet. or down more than 5 stairs. The other term you'll see in some of the older test questions is a significant MOI from a fall is 3 times the height of the patient. So if they fell from 12 feet and you're 6 and they were 4 foot tall kids and fell off the roof, that's 3 times their height. That's a significant mechanism of injury for them, especially when it comes to regard to the spine. So your axial loading, such as those occurring in dives, so if all of a sudden we hit dull when you hit straight onto your head, or fall and you landed straight onto your head, you'll get that. High speed motor collisions, especially with the rollover ejections. Anytime you leave the passenger's part of it, your head's sitting there whipping around. Your spine has a lot of it too. And then the high speeds, all of a sudden you're going from 20 miles an hour going 70 miles an hour, and your spine is the one that takes a lot of that injury, or a lot of that force is absorbed in the spine. So your ATVs or your motorcycles also, and then bicycle engine. There's your windshield. What do we call, if your head hits the window and it breaks the window, what's it called? The windshield. The break in the window is called what? Starring. So if you kiss the windshield and you break the window, they call it starring. So if you're seeing that, when you come up on scene and you see wherever a passenger was, this round indent and a nice break around it, they had a significant, either they were significant or they weren't buckled. Some other things though that we're going to maintain a high suspicion for: struck by a vehicle, blunt injury to the spine or clavicle. Anytime you have a diving accident, was found hanging by the neck, or was found unconscious from trauma. Some low risk would be low energy, so it's the same thing. Okay, like I've seen a few spinal and back injuries when they just fell out of bed. Low risk, but it still can happen. A drunk guy that was going way slow rolled off the road at 5 miles an hour. He didn't get ejected, wasn't a lot of high speed, but he still kept having injury. Penetrating trauma usually though is a low risk unless it was directly into the spine. Spinal fractures in elderly are oftentimes what falls or spontaneous fractures. They twisted wrong, they bent over wrong, and their bones were so brittle and just fractured. Consider underlying factors or pre-existing conditions that can make a minor MOI into a serious. Had a gentleman that had bone cancer, and somebody grabbing his arm broke it, trying to lift him in and out of bed. So he had bone cancer, had already susceptible bones. Somebody just lifting him around broke it. And then there's many other mechanisms can cause spinal injury. It doesn't have to be any of those. Just anytime you have an insult to that spine. I mean, it's the same thing. Somebody fell and hit the back of the table, they get hit. I mean, there's so many different ways. Anytime you get a direct hit to that spine. Some things though too, guys, mechanism alone doesn't identify the injury. So we're gonna have to look for specific indicators for spinal injury. A lot of the times it is those pain or tenderness. So when we're going to teach you the spider crawl down the spine. So every finger, you'll start at the base of the skull. Every finger should touch every vertebrae all the way down. And if you're feeling that and there's pain or tenderness on it, then we're going to suspect a spinal injury. A lot of the times too, depending on where the break is where we lose function to the body region. A lot of times your doctors will use that. They call it those dermatomes to identify where the potential fracture is, depending on what part of the body you lose. So some other ones too, the indicators of the spinal injury: paralysis of extremity, change in neural function, pain without movement, tenderness anywhere along the spine. We put that, impaired breathing. Was propria present? It's an erection in the male. for whatever reason, if you get that spinal and they lose control of the vessels, so they'll get that all of a sudden that great big drop in blood pressure, and then they'll get an erection with it. Loss of bowel or bladder control, deformities, and neurologic shock or neurogenic shock. I'm trying to think if there's any of those. Like I said, the big one is going to be your pain or tenderness as you go down their spine. So there's the algorithm that identifies the likelihood of it. They call it Nexus. So some key elements to it. I've never seen it or used it in the pre-hospital setting. They use it in the hospital setting a long time, but we do it. We just don't label it as Nexus, I guess. Is the patient reliable? What do we mean by that? Yeah, are they oriented? Can they talk to me? Do they have a distracting injury? If the answer is yes, they're oriented to me. No, they don't have a distracting injury, then we're going to say they're a reliable patient. Is there any pain or tenderness in the midline of the spine? That's where we're doing that spider crawl down it. Are there focal or neurological signs or symptoms? Meaning, what would we be looking for there? Loss of control of an arm, loss of sensation, and feeling that way as well. The distracting injury or circumstance. I guess I forgot circumstance with that one. So if they were in a car wreck with a spouse or child, and your spouse or child is hurt or dead, is that a distracting injury? And what is the MOI in a pediatric patient? What is the MOI in a pediatric patient? A lot of the times they can take a harder hit than you and I can, but we're going to look at that with them. Was it a 70-mile-an-hour head-on? Was it fell off the swing set? Anyway, look at those two with a child. And I've never figured out why they call it Nexus, because I can't put an N, an E, an X, or U, or an S on any of those to make it an acronym that I can use. So, but you're going to look for all of those things anyway. Modern spinal care is based on thoughtful assessment and good decision making by the ENT. This is where we're going to teach you guys this. The NRMT in this book has a really good way of doing the assessment. So the other word I like to put in there instead of thoughtful assessment is a consistent assessment. It doesn't matter the injury, you're going to follow the same steps so we don't miss anything. Rigid spinal immobilization can have a negative side effect. So this is where the backboard's really going away. If you have somebody with a lung injury and we let them lie down flat, it's going to be really uncomfortable and really could be deadly. And then even short periods can cause hypothermia and pressure sores, especially in elderly people that already have thin skin and susceptible to it. So your rigid backboard just going away, and for good reason. So for any spinal injury, we're going to oxygenate and make sure they're ventilated really well. Treat for severe bleeding, and then pay attention to the blood glucose capable. So the primary goal as for the primary assessment, we're going to try and treat hypoxia and shock as the same priority as the spinal motion restriction. What we're finding too with that is a lot of the times if we can get them on those body splints or in the cot, they're not moving to cause any damage to themselves, and they actually provide better spinal immobilization or restriction than we can for them. Err on the side of caution, protect against broken bone ends, even though the level of risk is unclear. Splint. If it's unstable and we can pat around it, a lot of the times that'll help the movement and patient comfort too. But we're going to do that by limiting the entire movement of the spine. I don't necessarily agree with this last one, and the research is backing it. Spinal mobile motion restriction prevents secondary cord damage by limiting the movement of the individual vertebrae. I guess I agree with the statement, but us taking that spinal motion restriction instead of allowing them to do that for themselves is showing to be more harmful than good. 3 centers of mass. When we start talking about these guys too, we have the body, the head, and the shoulder girdle and pelvis. So we can prevent those from moving, and it usually the spine will generally remain stable. So if they can't move their head, their hips and stuff, which is why the body splints and our gurneys work really well, because we can pat around and prevent that from moving. Remember I talked about patting. I love when Alpha Lynn comes on these with me because she can pat, and the shape of the spine is curved, right? It's not a straight line. So through your lumbar area, a lot of the times the bottom of your thorax, stick blankets, stick towels. Same thing when you lay flat. Do your knees want to lay straight or just a little bit of a bend to them? So we're going to pat underneath the knees. Any place you can find the void, pat. Manual stabilization of the head is the first step of spinal work. So anytime you guys come on scene with it, and we're going to teach you and be able to get hammered through this, you're going to come up, hey, can you tell me what happened? Or my name's Brandon, I'm an EMT, can I treat you? Yes. Okay, try not to move your head as I ask you these questions. And then you're going to take, and we're going to show you how to hold that head in a neutral position, just to help them not move it. If the head is out of the natural position, you can attempt to move it unless the patient complains of pain. If it hurts them to move it, then we're not touching it. If it hurts to move it from, bent to the right to try and bring it back straight, then we're going to transport them and pat pillows like crazy around their head and let it set wherever it does. We're going to talk to you about properly sizing a C-collar, all of that too. It's a splint though, so what do we have to check before and after? Pulses. And most of the time it gets checked after, but it doesn't get checked before. So which 99% of the time is fine, right? Because you're going to find it. But that one time you're going to check it and go, oh, I don't have a pulse. Was it there before or was it not there before? So it really is a good idea to check it before and after. Ambulance stretchers are now considered padded backboards that provide appropriate spinal protection in combination with C-collars and straps. And rigid backboards are less commonly used today. In fact, I think most ER docs would just assume Burnham was using them. They are still good though in some situations, which is why we keep them. Transport time is short. When the big splint is needed for multiple injuries, and then when the patient will likely need CPR. And what they're actually saying though too now is our stretchers, you can do CPR just as effectively on them as you can on the backboard. Respiratory distress and conditions are also contraindicated for backboards. We've already hit that. Scoop stretchers are great. Just be careful because they will go over theirs too, but they can pinch the patient really easy and it hurts when you pinch them. We'll go over the vacuum mattresses. Love them, love them, love them, love them. We used to talk, so this is a slide we used to talk about KEDs and spinal mobilization in a seated patient. What we found though is we were doing far more moving of the patient trying to get the stupid thing on them than just letting them get themselves out or sliding them onto a board. So the state of Utah we don't even teach them anymore. Yeah, the seated patient, they're not testing on it. We don't have to do it anymore. We'll talk to you about applying a long backboard. We'll talk about a standing takedown. We'll go over removing a helmet too. Okay, a lot of that stuff is hands-on. Give us 5 minutes, we'll start at like 8:05, 8:06, guys. Any questions on that too, I guess, for spinal mobilization before I call it quits on that? All right, guys, this will be a short one, 30, like 20 slides, I guess, actually 25. So we're going to talk multi-system traumas. So a multi-system trauma is more than one serious injury. For a multi-trauma patient, then a multi-system is one or more injuries serious enough to affect one or more body systems. So if we have a trauma that we have a musculoskeletal damage to the leg, and all of a sudden we also have a hit to the chest, and now we have a pneumothorax and a broken femur, we have multi-systems and different ways that this patient can die. Teamwork, 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 and transportation. Knowing your equipment is the best way that you're going to make this the outcome better for this patient. So most critical decisions, the priority and severity. If we have a major bleed and also a major airway issue, which one do we go to first? Airway, okay. And a lot of the times though, we teach that way in the test, and we test you like you're the only one on there. But a lot of the times the reason why we hammer airway on you guys is we want you guys to be the airway. So a lot of the times the basics are going to manage and suction the airway. The advanced are going to start trying to do bleeding control, get fluid going, some of that kind of stuff too. Whether to limit the scene time or not, if you have multiple traumas, a lot of this, you better be figuring out how we're doing it in the back of the rig. And then which hospital transport method is best for your patient. For us, we're still going to go to Southie Valley. It's not like we have multiple hospitals in the valley. But we're also could consider a helicopter if we have an extended extra, like car wreck, if we have an extended extrication time with some significant multi-traumas to the patient, and we're going to land the bird. Okay. Same thing if we're up on the mountain and we're 60 minutes away from a hospital, but we can get a bird there in 20 minutes, then we're going to go to the best place we can land a helicopter, and that's the way we're getting them out. So determining the severity. Oh, did I tell you? GCS is 15. The revised trauma score is 12. I told you that wrong. I guess I could have added up and did math. Remember how I said Excel does all my math lately? Anyway, so if they have a GCS of less than 14 with a head injury, if they're hypotensive because they're going into shock, or they have some kind of internal bleeding, and then anytime we have a head injury, same thing, or late stages of shock with the respiratory rate. And amputation proximal to the wrist or ankle. Pelvic fractures, same thing, they can lose a lot of blood into that pelvis or femur. Open or depressed skull fracture, and then paralysis of any kind. I'm determining too as far as where it happens in the body. If we have a penetrating injury to the head, neck, torso, or extremities proximal to the elbow and knees, why is it the proximal so to the elbow and knees? What's there that makes that a life-threatening severe injury? Yeah, all your major arteries and veins there. Head, neck, and torso, right? That's a pretty easy one. That's we're having respiratory issues. If we have any chest wall instability or deformity, that's if we have the flare chest. So if we're seeing that, or you're filling the ribs and they're filling 2 or 3 ribs are broken, so we're getting that unstable rib cage. 2 or more proximal long bone fractures, and crust or degloved, mangled, or pulseless extremity. Those are pretty self-explanatory on that one, yes, and on those ones. So a degloved is if the skin's been pulled off of an arm or a digit, usually your toe. If it's mangled and been caught in something. Industrial accidents is where you usually see those crushed, degloved, and mangled pulseless extremities. Same thing too, absence of anatomical or physiological signs, if the MOI is considered severe. So falls, when we consider a fall a significant MOI for it, same thing, 3 times the height of the patient or over about 10 feet, somewhere in that, or 10 to 12 feet. High risk auto. So if we get an intrusion of a lot of the times within, you guys know what intrusion is. So if you look at the car and the door was supposed to be out here and now it's into the car, pushed into it, that's intrusion. So if we have an intrusion that's 12 inches or greater, that's considered a high risk or high mechanism injury. Ejection for an automobile, obviously. If there was a death of a passenger in the same compartment, if it was hard enough hit to kill them, it's probably done some significant damage to the other occupant. And then the vehicle telemetry data consists of a high risk of injury. So if we had multiple rollovers, if we see long skid marks, anything like that to show that it was a high impact. And some other things too, older adults do not effectively, we hit on that, right? Older and young, the extremes in age don't compensate for shock very well. Children may benefit from transport to a pediatric specialty facility. We're lucky enough to have one in the state. Most of the time though, for us, they still got to go. We're not driving all the way to primary children's with an unstable child. So we'll go to a local facility, we can stabilize them and fly them out. Or once they're stable, we can take them by ground. If they take any anticoagulants, so blood thinners, they could have a significant because they can't control their bleeding. And if they're pregnant, because how many patients do we have? 2 or more, yeah. And especially late-term pregnancies, because baby's big, and so there's not a lot of room left in there, so they don't survive, or they don't take a hit very well. So a typical call, when does an EMT recognize that the patient has multiple injuries? Yeah, as soon as you see them, I promise you, if you get a patient with multiple, I can look at, like if I was this far, 6-8 feet away from Megan and she had it, I could look at her and go, oh shit, okay, there's some injuries there. So most of the time you're going to see it as you walk up to it. What's the, this ties into the third question. So what is the EMT's first decision about managing those injuries, and and why would you make it? So if I look up on you and we're out on the divide and I see a patient with multiple injuries, I have multiple patients. So there's 3 patients out there and 2 of you guys, or even one of you, only one of you has this and has multiple trauma, multiple injuries. What's your first thought? We're going to need more help. Okay. So I'm going to call a bird. I've got 3 patients here. One of them's serious, so I'm not, a lot of the times if we have 2 minor injuries, we can put 2 of them in an ambulance. There is no way I am throwing 2 serious patients into the back of a rig and trying to treat them. You just can't. Okay, so we're going to need some more help. And then another one, so on that, what body systems would you suspect to have been affected by their injuries? So it was a head-on out on the divide, single passenger in one car, 2 in the other. Single passenger is my one that I walk up and go, oh shit. Head on. So what injuries would I suspect to see in it? Airway. Okay, so it's damage to the chest. What if I tell you the intrusion in the front, the motor is setting at the patient's feet and the steering wheel's bent? So we're looking chest really hard at that point, right? Okay. And now we look at the other patient or the other car. It's a newer car, motor setting on the ground, but no intrusion in the passenger's cavity. Airbags are deployed. Patients were both buckled in. What injuries do you suspect there? So we can have some whiplash and head injuries. Okay. What usually happens? Airbags are great, but what also happens with them? Burns. Okay, so we're going to have to, and burns. Yep, exactly. If the airbag kissed their face, they're going to suck some of that in, and we can get some burns there. So we could have some serious airway issues with them. Okay, but no, perfect line of thought. We're going to need more help. We're looking at these injuries. This is what we're suspecting. So what actions would you take to support? So let's look at car one, single passenger in there, okay? Like I said, the motor's setting right at their knees, steering wheel's bent in. What actions are we gonna just take to support that affected body system? So we're suspecting with her chest and breathing issues, right? So what's some actions we're gonna take? Okay, so stabilize the spine. What about oxygen? So we're gonna put them on a high flow oxygen. Okay. How are we gonna if we're suspecting chest injury, how are we transporting this patient? Are we laying it flat? Okay, so we're gonna set them up. So if we're doing C-spine, what does that mean? Somebody's doing it now. Somebody's married to holding that head the whole time, which is great. That's the way they need to be transported. Okay, so let's move to the other vehicle now. The two occupants, red face, complaining of slight difficulty breathing. What are we going to do? No other injuries noted. They have some bruising from the seat belts. Oxygen, okay. What else would we want to do with them? I'd flush them. Get rid of that. So the chemical, yeah, brush it off, and then we're going to take a wet washcloth or whatever and try and wash it. If their clothes are soaked in it, most of the time we have gowns in the hospital or in the ambulances, so you could take their clothes off, their powder soaked stuff, let it, even if it's just their shirt, take that off and then give them a gown to put on. Okay, perfect. What priorities though? Back to patient one in the car. What's her priority? Okay. So we're not staying in plane. Okay, perfect. What other priorities do we have for her? You already hit it on the airway was a big one, right? Okay. What other ones are we going to want to do as we're maintaining an airway and height as we're going to the hospital? Okay, so we're going to strip clothing and check for bleeding, check for any other injuries. Okay. Because if the motor's sitting right here, what else probably femur? Okay, so we're going to want to look at that too. Perfect. Priorities for second car with those two. Not as serious, so they could stay for a minute till the next rig comes. Okay. A lot of times on those, you're going to have fire department and police, so you can brush them off and give them a wet towel. You can leave them with fire or police, let them get in their warm car or truck or fire truck, whatever. And then when the next shred comes on, we can take them. There must be scenarios that we're supposed to be tied to that because I'm going to make anyway. So some general principles of it too. For all of the priorities determined by the primary assessment. Primary assessment is what? What's covered in it? Your ABCs, right? Airway, breathing. Okay. Remember the golden hour. And it's not 1 hour from when you get to them. It's 1 hour from the injury. So if they got in a wreck and it took us 30 minutes to get them out, we're already halfway through the golden hour. So that's on those. That's when we're looking at the helicopter or whatever. And do they need a level 4 trauma most of the time, or do they need the level 1? So 4 is lower. Mount Pleasant is a level 4. They have a lot of great abilities. Utah Valley is a level. So they need a level 1. Actually, no, Utah Valley is a level 2 because they don't have a university. Okay. IMCs are level 1 or U of U. Limit the seeding treatment. So we're going to stabilize that C-spine, suction the airway. If they can't protect it, we're going to try and put in an oral or a nasal to restore it, ventilate and bag mass, high flow oxygen, control bleeding, and restrict spine motion. These guys will scene safety is paramount. If it was dangerous enough to get them hurt, it was a real danger for you guys. Even a car wreck, right? How many times do you see on the news that a police or a fire truck or something was hit? Okay. Open and airway, always perform urgent or emergency moves as necessary and adapt to the situation. No scene's going to be the same. No injuries are going to be the same. you've got to understand the principles behind it and we're going to move with it. This is your trauma scoring or your revised. So it's a numerical rating system for trauma. It's assigned to certain patients' characteristics given a score. It objectively describes the severity, and the transport and trauma centers are going to use them. It helps them evaluate the care of similar patients. So to take it, it takes the Glasgow Coma scale to systolic blood pressure and respiratory rate. And do not let it interfere with the patient care. This is the same thing. The hospital is usually the one that's going to do this. So there's your revised trauma scale, and it is 12. Glasgow Coma is 15, and your revised trauma is the 12. Because I can even do 4 times 3. It's not that late in the day yet. All right, and that's it for this chapter. A lot of it does come down to what we talked about with the scenarios and managing them and getting your priorities. Give me just a second. We're going to hurry and switch over and try and get the 4th chapter. All right, guys, so this one is chapter 35. We're going to cover environmental emergencies. It's 88 slides. We're going to try and get through as many of them as we can. We'll probably end up finishing it. I'm not sure yet. So topics we're going to cover: exposure to cold, exposure to heat, water-related, high altitude, and bite systems. So environmental occur in any settings. It can be wilderness, rural, suburban, or urban. Exposure may not be only danger. So meaning it can they can have a pre-existing condition or cause additional medical problems. So somebody that has an underlying heart condition, if they get stung by a bee, is going to exacerbate that and make it worse. We'll get up with that. So some terms that you guys are going to need to know, especially when we start talking about treating for shock. So conduction is how we lose body heat. There's 5 different terms we're going to cover. So conduction is direct contact or a water chill. That means, so if they're laying directly on a wet, cold surface, they're going to conduct or lose their heat that way. Convection, I always remember the conduction oven is you put it in there and it just heats the whole thing or cools the whole thing. A convection oven does it with air too. So convection is we have air or water to carry away the heat. Radiation is heat is picked up by its surrounding air or water. Usually that's what you gals do when you go to bed, is you radiate heat. I didn't say that either. I'm gonna get in trouble, you guys. Evaporation occurs when the body perspires and gets wet, or like I said, we think about perspiring, but a lot of the times wet. That is the best, fast way to get rid of water. If you get them wet and then put a little air on them, so you use both evaporation and convection, you can suck a lot of heat in a hurry. And then respiration is loss of body heat through exhaled air. Dogs are the big one that you see with that. That's the only way they can cool themselves very well. So some generalized hypothermia is exposure to cold and reduces the body heat. The body's unable to maintain. And when we start talking about hypothermia and hyperthermia, it's the core temperature. When we start, it's not just the arms. We're always looking at the core. So we're unable to maintain that core temperature, may lead to death. That's why the predisposing factors, if they're shocky, why we're so worried about it, is we got to keep that core warm. Infections or immobility, injuries, diabetes, they have a hard time maintaining body heat, and influence of drug or alcohol use. So some obvious and subtle exposure. So if we have alcohol ingestion, we had one 2 or 3 years ago in Mount Pleasant, but we got drinking at Christmas and went out, just laid down and died in the snow from hypothermia. Underlying illness, if you're sick or whatever that way, overdoses or poisoning, major traumas can cause it. Outdoor resuscitations. A lot of the times we kind of can shoot ourselves in the foot. If they're in a cold area and we're trying to resuscitate them, it's not going to help. Not going to do a lot of good if their body temperature is really, really cold. And then decreased ambient temperature, that's your frostbite. Right? It's like out here right now, we definitely have a decreased ambient temperature outside today. Same thing, the effects of cold temperature on older adults are immediate. Same thing with children. Like a newborn, the fastest way you're going to get them in trouble is if you don't put a hat on them or whatever to control their body. And it is a sad fact that in the winter, a lot of times, I think this winter is going to be brutal for this one. They live on fixed income and they have unheated rooms or rooms that are kept too cold, so they just can't afford to do it. Environment plus slow body system, and they can lead to hypothermia. I really worry about that one this summer for us. With the pediatrics, same thing though. The big thing with them is they can't shiver due to small muscle mass, so they can't create a lot of body heat, and they don't have a lot of body fat. I can withstand a lot of cold if we're going off of that theory. So some signs though that you're going to see with these guys: early stages is shivering. That's a good sign, right? The body's trying to create heat and energy through muscle contractions and that shivering. Then you're going to see the numbness or reduced loss of sense of touch. And then you're going to go from there to kind of that stiff and rigid posture. Drowsiness, they get tired, everything's starting to show down. You're going to get that rapid breathing and pulse. Or you can get with and or slow and absent breathing and pulse in prolonged cases. So a lot of the times we'll start breathing faster, start trying to beat faster, and then all of a sudden you'll get slow, you get slower, and then all of a sudden you'll have prolonged without either. Loss of muscle coordination. It's basically because the neurons are frozen. They can't send, they're so cold, they can't send that nervous back and forth. Joint or muscle stiffness, same thing. It's got all that fluid in there and it's literally starting to freeze. Decreased level of consciousness, or they're just flat unconscious. Cool abnormal skin, and then they can get the red skin and or cyanotic skin in prolonged cases. So what are we going to do about it? A lot of the times we have to be passive when we're warming these guys up. Because if we do the active and apply that to it, we can send the body into shock. So if they're in really, really bad cases, the best thing is get their wet clothing off, cover the patient in a warm blanket, and then crank the heat up in the back of the ambulance. Once we kind of get their body temperature up and they're starting to cognitively talk to us, can respond, then we can start actively heating these patients. So anyway, so we're going to remove all wet clothing. We've talked about that. Actively rewarm patient during transport. Provide care for shock. If alert, give a patient warm fluids at a slow rate. Emphasis on the slow rate. If you give it too much, it's going to come right back up. Transport patient unless a mild case. So this is showing rewarming a frozen part. One of the things though that I wish that we'd hit a little harder on is once you rewarm it, you have to be able to keep it warm. Because if you rewarm it and then refreeze it in a short amount of time, you're going to cause significantly more damage than if you'd have just left it stay frozen. So if we rewarm a frozen part of the body, we have to be able to keep it warm. So some extreme hypothermia, they're unconscious, no discernible vital signs, heart rate of 10 beats or slower, very cold at the touch. If there's no pulse, we're going to just go into our CPR algorithm. If the pulse is present, care for it as if any other unresponsive or not responding appropriately. Same thing, we're going to start warming them gradually, and then we're going to start actively warming them. You just don't want to shove them from a core temperature of 30 Celsius to a 36 Celsius in 5 or 10 minutes. You're going to shove them into shock. And then you're not dead until you're warm and dead. Yeah. A little morbid, but it works, right? So care for them, ensure an open airway. We're going to apply high concentration oxygen. If possible, we're going to pass it through a warm dehumidifier, wrap them in blankets, and transport immediately. And they ensure the open airway. It says provide high concentration oxygen. A lot of the times, though, you're going to be bagging and not a mask with these. Okay. So local, so this is most commonly affects ears, nose, face, fingers, anything that's a small tissue farther away from the heart. We just have a hard time keeping it warm. The tissue may form ice crystals, which is what causes the damage. Those crystals have really sharp edges and you start lysing cells, and it's not good. So early or superficial, we're going to remove the clothing, move from the cold and cover, so get the frost nip. Late or deep, so that frostbite, we're going to give them oxygen. We're going to cover it and handle it gently, because you can pull that right off. You guys seen Pirates of the Caribbean when they're sitting there and the guy pulls his frozen toe off? It's funny, but it can happen. So, and then they're painful. They're really, really painful. So I really don't want to explain to the dog why I'm holding his frozen finger as we walk in today. So you'll see a lot of times with frostbite, it looks that dead blackened skin. I mean, it's dead. That's anyway. There's not a lot. They'll go in and debride that, clean it all out. And sometimes they can get it to come back, and sometimes they can't. So actively rewarming frozen parts should seldomly recommended. Our protocols don't allow for it. So because there's a chance of that permanent injury, or if medical direction instructs you, and transport will be severely delayed and you can't reach medical direction. So warm water in the container, immerse the entire injury or site without touching the sides of the bottom, so you're not floating in that warm water. This is the other hard part. To actively rewarm it, it has to be between 100 and 105 degrees Fahrenheit. How in the heck do you heat water to 105 to 100 degrees Fahrenheit in a day? It's just, and if you do it in the home, how do you not get it over? And all of a sudden now you went from a frostbite to a burn. Interestingly enough, though, they go to the same place because they do the same treatment for it. They do breed and get rid of that dead tissue. Remove clothing or jewelry bands or straps, fully immerse, and do not allow the area to touch the sides of the bottom of the container. Continuously stir the water. If you complete the rewarming, gently dry the affected area, apply a dry Stella, keep the patient at rest. Make certain the entire patient is warm, right, as possible. Continue to monitor the patient. Do not allow the limb to refreeze, and transport with the limb slightly elevated. So heat exposure. Heat is not needed for temperature maintenance and not lost. So it creates the hypothermia. So we're not able to either sweat or get rid of that heat. Left unchecked, it will lead to death. Starts with your heat cramps and heat exhaustion. At that point, the skin is usually moist and pale and normal to color skin that way. Normal to cool skin as far as, so this is CTC, right? So condition, temperature, and color. When we're looking at this one, the skin, that's the term you'll hear it as a CTC. So its condition is moist, its color is pale, and its temperature is cool to the touch. The difference between it and heat stroke is it's dry and hot. Usually the moist skin will go away quickly. And then it'll just be that hot, dry skin. Patient with moist, pale, or normal color skin is the heat exhaustion. Sweating continues, the body loses salts, and you get those muscle cramps. Also, if they we'll talk about it in a second. So healthy individuals may experience a form of shock brought by fluid loss, and it's a salt loss that we're losing it for. Often, too, people have not acclimatized to the summer heat. So that first time in the summer when we decide we're going to go out and mow the lawn or do whatever, or we're going to go for a run, it's been 60-degree weather and all of a sudden we're running in 90-degree weather, we'll go into that heat exhaustion. Some signs and symptoms, you'll see that muscular cramps, there'll be weakness or exhaustion, that rapid, shallow breathing, you're trying to get rid of the heat through the breathing, weak pulse, heavy perspiration, and loss of consciousness. Possibly, but it's usually brief. So to treat them, get them out of the hot environment, put them in the back of the rig, turn on the AC, do whatever we have to that way. Administer oxygen for signs of hypothermia, loosen or remove clothing. We're going to put them in the supine position. Small sips of water. Most of the time, though, we talk about both of these, warm fluids or cold fluids. The hospital, and we usually don't do anything by mouth just because they've been bombing it back up. Apply moist towels over the cramped muscles and then transport the patient. So heat stroke is a true emergency. They no longer can control their body temperature. And they can't get rid of that excessive heat. So they will stop sweating and cannot lose heat through evaporation. They're going to go unconscious on you, have that rapid, shallow breathing, same thing, they're trying to get rid of the heat any way they can. They're going to have a full rapid pulse, generalized weakness, little or no perspiration, sweating, dilated pupils, and potential seizures, and no muscle cramps. The seizures are coming from they've lost that salt, so that sodium potassium balance is gone. So we're going to remove their patient's clothing, apply cool packs to the neck, groin, and armpits. Usually, though, in infants and children, we're going to use that lukewarm or tepid water. You don't want to send them into shock. High flow oxygen, transport immediately. So as their body temperature decreases, you're going to start to see those muscle shivers. Heart is prone to dysrhythmia. It's the same thing. There's sodium, potassium. We just lost so many electrolytes that go with the water that it throws that off in the heart. As the body temperature increases, we're going to see the sweating, evaporation, cool skin. And then if excessive heat builds up, we're not able to get rid of it, then the skin becomes hot. Water-related, boating. We've got to have a lake to have any of these injuries lately. Windsurfing, jet skiing, diving, and scuba diving. So some things with it, airway obstruction, right? If we were in the water and took a good gulp of water down in the airway, we would have that obstruction, suction, cardiac arrest. We have signs and symptoms of a heart attack, injuries to the head and neck, generalized cooling or hypothermia, substance abuse and drowning. Substance and boating usually don't go together very well. The generalized cooling or hypothermia and drowning, like Fish Lake, that kid that drowned 2 or 3 weeks ago now. Anyway, that was what got him. He just got that generalized cooling, body shut down, and then he drowned. According to the WHO, drowning is a process of experiencing respiratory impairment for submersion in a liquid. Outcomes are death, morbidity, or no morbidity. Oh no, shit, Sherlock. Anyway, I guess so on that one, you can have long-term effects, and some people have no effects if you were able to revive. Drowning often begins as the person struggles to keep afloat. When they start to submerge, they try to take one more deep breath and usually suck water. And then they have that coughing, spasm, involuntary, and involuntary swallow. But they also can have that reflex spasm of the larynx, which triggers stilling the airway. But the hard part is that now they can't get anything. And then they call it a dry drowning, because there's no water in their lungs, but they drown. And so if we pull them out and that's still there, we also can't get water or air into the lungs. Most attempt at a final breath are unconscious in the water enters the lungs. So stop. So rescue breathing in or out of the water, do not stop. You're going to begin rescue breathing without delay on these guys. If you reach a non-breathing patient in the water, support them in the semi-supine patient and provide ventilation. We don't train for water rescues. Let somebody else do it. If they come unconscious, we've had far too many rescuers that get drowned because the patient starts fighting them and we're not trained in how to get rid of them or how to deal with that. Let somebody that is deal with it. You may have to be a little more forceful when you ventilate these patients, and then aggressive suction too. Assume that the unconscious patient has a head injury or neck injury as well. Unless somebody can tell you for sure otherwise, we're going to make that assumption. Resuscitation should be started before you mobilize the neck and spine, and may not be able to complete assessment for spinal while they're in the water. And you're just not going to. You got to get them out of the water and someplace where we can start treating them. Take care to avoid aggravating spinal injuries, but do not delay basic life support. Keep their head and neck supported in a straight line if possible. And then information supplied to the dispatcher hospital for the scene during the transport is critical. How long were they down? How long were they resuscitations? All of that kind of stuff they're going to need to know. So most of your diving accidents usually involve the head and neck, but also may involve feet and spine too. So did we dive head first or feet first? You see this down in Powell a lot with cliff diving. They'll think that they're safe because they jumped feet first and didn't realize the rock was a lot closer than what they thought. Emergency care is the same for any accident patient out of the water too, though. So some other things that you see with scuba diving, you get the gas bubbles in the bloodstream. So it's usually a nitrogen poisoning is what they call it. Can be inadequate training, equipment failure, or underwater emergency. You're trying to conserve water. So if they have an emergency and have to rise too fast, is a lot of times where you see this. Depression sickness is the diver surfacing too quickly from a prolonged dive. It takes 1 to 48 hours to appear. So they get that air embolism, altered mental status, rapid loss of consciousness, blurred vision, and seizures. Some other parts of it, paralyzed or paralysis, yeah. Either they're completely paralyzed or one of their arms or legs won't work for them, okay? Or it'll mimic a stroke, numb or tingling sensations. They'll have that generalized weakness. If it's a late sign, they'll have that frothy blood in their mouth. It's just a pink frothy sputum. Incontinence, so they can't control their bowels, chest pain, and stroke-like symptoms. So some other part of it too, that can resemble a myocardial infarction, so it's a heart attack, right, or respiratory cardiac arrest. Same thing, depends on where that air embolism went. The decompression, we've already hit that. The muscle and joints, the bends is what they call it. Itchy or bloody, molting skin, that's the nitrogen getting trapped underneath the skin. Choking or coughing, substernal pericardial chest pain, meaning that it's out on, feels like it's on the rib cage itself. It's on, coughing and peripheral edema, swelling. So same cares, we're going to maintain the airway. They really need oxygen to keep them warm. supine or on their left side, continue to monitor them. Suction, 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 contact medical patrol, and then the property transportation. We actually have hyperbaric chambers, which is where they're going. Utah Valley has one, IMC has one, U of U has one. So, what's that? The LDS has one, yeah. Ogden Regional, I know there's quite a few of them actually in our state. Water rescues, we'll talk about it. So hold an object for the patient to grab, throw an object to a float, roll the boat to the patient, and swim to the patient is the last resort. Even roll the boat, unless you have a really stable boat. I'm not rolling anywhere near you. I'll drag your butt back to the lake. Ice rescues, scene safety, scene safety, scene safety. Number one rule, protect yourself. So there's different ways to reach them. You can throw a flotation device, toss a rope with a loop, push out a flat bottom aluminum bolt or ladder flat on the ice. James Roberts actually had a guy that he was going to Heber out on Deer Creek, and he watched it fall in, and he hurried and grabbed his ladder and was able to get the ladder out to him on the thin ice. He was able to climb on that and come back. James, that guy got out, climbed in his truck. Took James a minute to get the ladder strapped back down. He went up like a quarter mile and went back out on the ice. So, you freaking idiot. Maybe natural selection was there for a reason. Anyway, treat the patient for hypothermia. Remember those two, they may not be able to reach or do much to help in the rescue process. These guys always need to be transported. Do not walk alone and do not walk out on that ice. It's the same thing. You're not trained for it, and the last thing we need is for one of us to go down, and now we have 2 or 3 patients and 1 rig out and only 3 others available. So anyway, we had one before my days, but we actually had one out on Wells Rest too. That happened too. In the winter, they went out on the ice. We've had 2 of them out there. One that, and then one that got flipped out of the boat. Anyway, all before my time. So high altitude sickness, difference in, so as you get higher there, we have less oxygen to breathe and then decreased air pressure. Most of the time, if you're normal, healthy, you're just fine and we balance into it. But you can also get the acute mountain sickness. Usually it's a less serious case, adjusting to the thinner air. Mild cases may need to overcome at rest, rehydration, and altitude. Severe, they can need oxygen, immediate descent, that should lead to improvement. So high altitude cerebral edema is the worst form of the sickness. They get that severe headache that worsens over time, loss of balance, severe fatigue, seizure, altered mental status, and loss of consciousness. If you're seeing that patient care, we got to get these guys down to a lower altitude. All other treatments are secondary to this because it doesn't matter what we do, even high concentration oxygen. If we can't get them down, they're going to continue to deteriorate on us, and then provide supportive treatment. Signs and symptoms, same thing: shortness of breath, cough, a dry cough that progresses to a coughing of blood or that sputum, tachycardia, tachypnea, a mild fever, oxygen saturation lower than other asymptomatic people in the same environment. So let's say we all are at 8,000 feet and we do it. I'm at 94, Elizabeth is at 94, Glory's at 94, and all of a sudden you're at 80, okay? Or 88. You could have it. It's just got to be compared to all of us. So yeah, immediate descent, high concentration oxygen, minimize physical activity, and supply supportive treatment. Insect bites and stings. All spiders are venomous. Insect stings and bites are rarely dangerous. Anaphylaxis shock is our big concern, and we're going to remove the stinger quickly. So there's a sign of a bite, right? That's a brown recluse one. We don't have them around here, thank goodness. So signs and symptoms though of an insect or bite, spider bite, we're going to get that altered mental status, notable stingers or bites on the skin. So especially the puncture marks, a lot of here we have the stupid earwigs that you can see them. You can see distinctive, the two prongs when they bite you. What's that? They do. Blotchy or molted skin, localized pain and itching, and then numbness in the limb or body part. Same thing, the burning sensation throughout the limb, the redness, the swelling and blistering. In severe cases, you'll get the weakness and collapse and difficulty breathing with an abnormal pulse and headache and dizziness. Same, you'll see some chills and fevers, nausea, vomiting, muscle cramps, joint pain, excessive saliva and profuse sweating, and then anaphylaxis. So what do we have to do with these guys for airway a lot of times? Suction them. Emergency care for them, we're going to treat for shock. If you do not have specific protocols for to give an EpiPen, then we're going to call and get either medical direction or call ALS and get them coming. Remove the stinger or the venom sac. Okay, we want to get rid of whatever we can so it doesn't keep dumping that into the body. You're going to get some swelling. So any jewelry or anything that could affect your CMS, we're going to get it off. Place constricting bands above or below the sting if your local protocols permit. Most do not. And then keep the limb immobilized. Any anaphylaxis is a big one with that. Other than that, a lot of the times remove the stinger, give them oxygen, and suction the airway if they get a lot of saliva. Snake bites usually are not life-threatening, but do require specific care. It's usually not sudden unless anaphylaxis shock develops. I've never heard of anybody have anaphylaxis to a snake bite though. Keep the patient calm. Pressure and immobilize the bandage may be most effective to slow the venom spread, but we're not cutting and sucking it out anymore. That's long gone. Signs and symptoms, you can have a bite mark. You usually have the discoloration and the fang marks. Usually taking 30 minutes to several hours to develop. And then the rapid pulse and labor breathing, especially for here, what's the one we generally see in a snake? So a rattlesnake. So you'll see that rapid pulse and labor breathing. Progressive generalized weakness, usually starting from the site of the bite. Then you can get goes to vision problems, nausea, vomiting. Severe cases, you get seizures, and then drowsiness and unconscious. So some key things for you guys to do: call medical control so that they can get some of those antibodies coming. Treat for shock, conserve body heat, locate the fang marks, and if you can, so let's say there's a 1-inch red mark, draw a dot around it and note the time so we can see how fast and how large it's spreading. Same thing, you're going to see some swelling, so we're going to remove any jewelry on the extremity. Keep it immobilized. We're going to try and limit the blood supply and need for that limb as much as possible, and then transport the patient. So marine life can occur in various ways. It's usually improperly prepared seafood or poisoning organisms, but you can get stings and punctures. For us, I don't think we have any freshwater fish or things like that that we'd have to worry about here. Increasing pain though, use salt water to rinse the affected area. And a lot of the times when we talk about seafood, that's like your if they're not cooked and they get the toxin, what is it? Like a blowfish, it's a neurotoxin that causes paralysis. Anyway, we actually made it though with 4 minutes to spare. When we start talking on environmental emergencies and stings and bites, though, a lot of the times it's just get them if they're hypothermic, get them warm. If they're overheated, then we're going to get them and turn the AC on. and the rig, do whatever he can to get the body temperature down. We want to do it quickly, but in a controlled manner, if that makes sense. You just don't want to go too extreme too fast. Bites, oxygen, immobilize it, whether it's a snake or a spider, mark the edges of it, note the time, and then transport. If you don't have ALS, get somebody there because you can't get the hypothermia or anaphylaxis shot. You'll need a shot of epinephrine. I think that is it. Will and Jessica. Still have to go. Or Will. We will start hands-on up at the mine the first week in December. For you guys here on the Sand Creek side, it'll be the first Wednesday in December, and it will be over at the fire station. And then I will post a schedule before I go out for surgery next Tuesday. It's my last day for a couple of weeks, but I will post a schedule on the EMS or on the board just outside of Cooper's office. Any other?
Thanks.
Yep. Well, unless you guys have anything else, we'll call it a night. Is the first of Wednesday? That'll be the first.